Hello, good morning. I'm Ashok Kurokode, consultant rhinologist and anterior skull base surgeon from Winchester and University Hospital, Southampton, UK. I welcome colleagues from around the world on behalf of organizing team to the second day of inaugural Winter Global Rhinology and Skull Base Surgery Webathon. Global Rhinology Network is a non-profit organization with a mission to foster surgical education in rhinology and skull base surgery. We have successfully hosted annual multi-center live surgical webcast, The Lioness, since 2014 in collaboration with Lion Foundation. Thousands of surgeons from all corners of the world have benefited from it. More than 2,000 surgeons from 110 countries have registered for GRACE 2020. We had hugely informative and engaging 15 sessions on endoscopic sinus surgery presented by eminent rhinologists and skull base surgeons on day one. We'll be having similar sessions today focused on anterior skull base surgery. This event is hosted at the Global Telemedicine Studio of Professor Wilco Grolman in Utrecht, the Netherlands. It is supported by Medtronic and Karl Storz.
Imagine, what if you could do even more to bring relief to your chronic rhinosinusitis patients with technology customized to your unique clinical and facility needs? Introducing Stealth Station Flex ENT Navigation System, a customizable system from Medtronic ENT, a market leader in image-guided surgery technology. Featuring 6 hardware configurations, an optional portable card, 2 different electromagnetic emitter options, with flexibility in hardware design and optional software functionality. Get everything you need and nothing you don't with Stealth Station Flex ENT. Let's flex forward. Contact your Medtronic representative to customize a navigation solution that's right for you.
So can I invite Claudia Colejas? She's our rhinology skull base colleague from Child to host Jim. Welcome, Claudia.
Thanks, Ashok. Hi, Jim. Good to see you again. Great talk, by the way. Well, Professor James Palmer doesn't really need much introduction. He's professor at the Department of Otorhinolaryngology, Head and Neck Surgery in Penn University, where he's also director of the fellowship program and director of the Rhinology division. He's co-director of the Penn Center for Skull Base Surgery. And he happens to be also a good friend of our ENT department in Chile. He has supported us, so thank you very much for that, Jim. And he's really an outstanding speaker, and I'm really looking forward to hear your talk on pediatric skull base surgery. Please, Jim.
Claudio, thank you so much for hosting me, Ashok. A lot of work. Thank you so much. This has been a lot of fun to do. Let's share my screen and then get going on pediatric endoscopic skull base surgery. I have to admit, following Danny Prevedello is tough. And this will be more of an ENT perspective, for better or worse. And we'll work our way through some endoscopic pediatric skull base surgery. The first thing is that, especially with these children, you have to be careful that the diagnosis can be tough based on imaging. And there's not as many neuroradiologists used to looking at children's films. And here's a patient followed by neurology for what they claimed was a Rathke's cleft cyst, and they thought this what it was and just watched it, eventually worsening vision, so they got consulted, and then it's a craniopharyngioma. The thing that can help you pick this up is the CT scan. The CT scans sometimes show a little bit of calcium on them, and that will help pick up what's there. Oftentimes these kids actually present with hydrocephalus. So one of the things that's difficult about them is we rarely get early diagnosis. It's usually hydrocephalus or loss of pituitary function because the pituitary has been mashed by the craniopharyngioma. And so you end up sort of coming in after damage has been done, unfortunately, because of the later diagnosis of that. Here we've got one that presented with this large hydrocephalus. So we've already, this is at the end after removal, taking a look at the areas that we are. And they will get fairly large, and they'll get into lateral ventricles, and it's very common to have lateral ventricles exposed. I like to show this one because there's the shunt that was put in, and that oftentimes will be what we do. They present with hydrocephalus. We put a shunt in, give it a little time to settle down, and then we'll come on back and remove the craniopharyngioma. And so depending on the age of the child, the situation, it's okay to wait. Remember, this is benign disease that's oftentimes gotten quite large before they got here. Now, traditionally, these have all been removed open. Craniotomy and coming down on them. And here's a picture from one of Jay Storm, my neurosurgery partner, back when he did these open. And in many ways, this story for us in this lecture is a story of combined success between two institutions and working together as a team to learn. So this is Nithin Adapa, my partner, and me, and I find that you usually probably need to have 2 ENTs to keep one neurosurgeon happy. This is the time when we actually have 2 ENTs and 2 neurosurgeons together for our pediatric cases. Jay Storm, our pediatric neurosurgeon, John Lee, our endoscopic neurosurgeon at HUP. And the story is a great one. Jay says, you know, we probably should be doing these craniopharyngiomas endoscopically. Talks to John, says, John, why don't you come over and let's start working on this together? John says, you got to get the ENT squad. So we actually, for the first learning how to do this, we first identified the patients at CHOP, and CHOP and HUP, which is Hospital University of Pennsylvania, are next door to each other. Believe it or not, pediatric anesthesiology demanded to put the kid to sleep at CHOP, move them across the street. There's an underground connection, and up to the OR at HUP. And the reason why we did our first cases in the OR at HUP was that's where our nursing was, that's where our equipment was, so we could get this all going. This was around 2010 or 11. And then once we got Jay on board, we brought the pediatric nursing team over to work with us. They learned how to do it because it's so important to have nursing and the rest of the team and your whole team working together. Then we moved over to CHOP, worked on it, and now it's become something that's almost a commonplace a couple times a month. What are the challenges? From my view, the paranasal sinus is very important in terms of a challenge to get there, the exposure, extradural bone exposure, harvested nasoseptal flap, and reconstruction. Frankly, the sinuses aren't as big a problem as the entrance to the nose. That right at the beginning is the tightest thing. And here is our first patient, 2011. He's now shows up with his emo hair across his face and starting college. So it's fun to see these kids as they grow and do well. So paranasal, let's talk about the paranasal sinus exposure first. The exposure requires crossing 3 bony anatomic landmarks: the nasal aperture, the entrance into a completely pneumatized sphenoid sinus, and IGS is very helpful for this, and you really want to use that each time, and then exit through the sphenoid base into intracranial fossa. That's helpful also. The nasal aperture actually is the tightest spot for us. The soft tissue can be manipulated, but you need to avoid damage to it. So we'll actually start with pediatric scopes for the first incisions, getting our nasoseptal flap up and getting the inside of the sinuses set, and then we'll flip right back over to adult scopes. This does aid in development of the upper midface for the first 10 years of life, and there's multiple instruments entering and exiting, so just careful with that area. The rest of the sinuses we'll go ahead and open up, and you'll see in my videos, maxillary, ethmoid, and then get the sphenoid, open up both sides, take both middle turbinates. We have had no issues with our kids as they've grown. We're now pushing a decade of experience with these kids, and they're all doing very well. When we've had we've gotten multiple MRIs to follow them, and their mid-face growth is just fine. So don't spend any time worrying about those. Now, how about the sphenoid? It's sometimes difficult to visualize exactly where you are. That's why you'd like to have IGS, pediatric endoscope, pediatric instruments, resect the middle turbinate, IGS to get there. And then you switch over to the adult following a septectomy. You're going to get better optics. And frankly, you just need to create a new sphenoid. That hasn't been pneumatized for you, so you have to pneumatize it. And so if you look at the different ways the sphenoid looks, and this is almost something that as an ENT resident you have to know for your second year tests. You've got the Cellar model, the pre-Cellar, and the Concal. Now the Concal is going to be the one that you're going to use IGS for. Actually, we use it for all of them. And this is the one you have to drill to certain amounts. And so it can be extensive due to the incomplete sphenoid pneumatization. There aren't much in the way of landmarks because there's no optic carotid recess or bony prominence, and you sort of have to make them on your own, staying midline and working your way further. You will notice a difference from when you're drilling through cancellous bone until it starts to get tighter and you lose that cancellous part. Then you know you're almost there to where you need to be. Careful about the intercarotid distance, and you really need to be careful to make sure you give yourself a large enough surgical corridor, or you're just going to be stuck. So here we are on a case running right into where things have turned to bone. So in these young children, that cancellous bone is a little more vascular and obviously creates some visibility issues. So you really want to be binostril at this point. And you're suctioning and drilling, and you just have to take your time. Sometimes this can be the longest portion of the procedure, is just getting this cancellous bone out and recreating a new sphenoid sinus. So lots of drilling, frequent location, because you don't have landmarks and checking on it. Next thing, intercarotid distance. Fortunately, even in these young kids, there's actually a reasonable intercarotid distance that's present. It doesn't change a whole lot from these little 24 months. And you look at these kids and they're just so little, but their intercarotid distance isn't bad as compared to an adult. So you've got enough room to work with. And here we are in a situation where we're making our corridor to work and then being careful about the distance there for the intercarotid area. Next step is thinking about developing an instrumentation corridor. If you notice, you see how it's just not wide enough to two instruments well into the nose. And we've gotten more sophisticated at this. This is an early day video for us. And sometimes we'd feel like we could only get one instrument in to work intracranially. My answer for you is to do more drilling and get that corridor wider. And we get that corridor much wider now over the course of time. So how about intra-op dissection and removal? So this will be one of our cases. And the first step on the sinus part is well known to this group, which is go in the nose, take both middle turbinates, open up maxillary and ethmoid sinuses, raise your nasoseptal flap, drop that into the nasopharynx, and then we'll do a wraparound flap from the other side. So we've done a posterior sectectomy to get us to that area of the sphenoid. And we talked about the sphenoid drilling. Once you do that, then you're ready to move intracranially and start taking things on. So I'm going to jump forward now after you've seen the parts, because we're going to go over these again later. There's a nasoseptal flap being dropped down, and we're going to put that down into the nasopharynx, and then we're going to go ahead and get ourselves to the sphenoid sinus. So now we've got the sphenoid sinus exposed. Time to start drilling and get ourselves into our intra-op dissection. I apologize for that. Let me do that again so I can get us up to the right spot. I didn't want to catch that wrong. What I want to do is get here, because now we see the cyst itself. So this is actually key for us. Go into the cyst, take down that anterior wall of the cyst itself and go into the cyst. And I jokingly refer to the cyst itself as sort of like Santa's bag, and it's full of a bunch of presents. Now, sometimes those presents, you just go in, it's entirely cystic, it's fluid, you suck it out and you're done, and then you work on the cyst wall. Other times it's full of a bunch of big calcium rocks. Unfortunately, sometimes those calcium rocks are so big, they don't want to come out of the opening that you've created because they are bigger than the opening itself. In those situations, four-handed technique, I'll grab onto the calcium rock itself, pull it into the center of where the cyst is, and then Jay Storm will take another instrument to hold on to the rock also, and then he'll drill it into pieces intracranially, and then we'll take the pieces out through that hole. And so obviously that takes a long time and is a dicey proposition, but also important, or otherwise you don't decrease the decompression. So first step, go into the cyst itself, remove contents. Now you can get onto the cyst wall itself and go for gross total resection. I'm going to move this along a little bit further here. And in many ways, you almost need to work like the clock, where you work at one section for a while, like 1 o'clock or 11 o'clock, and then move down to 3 o'clock, move inferiorly, step by step, little by little, start working on the edges of the capsule. And it is okay to do general retraction on these kids. You know, it's having spent my life assisting adult neurosurgery before we did this, I was really worried about giving a little bit of retraction to these cyst walls, but it turns out it works very well. Obviously, you've got to be careful, but a little bit of retraction and then dissection around will help you be successful to get these out. And here we are, sort of last step. Optic nerve, a little bit of bleeding up there, and we're in pretty good shape. So how about reconstruction? So you've gone ahead and taken everything out. Now we've got to reconstruct. We don't do this anymore. This is a picture left over from my book that was around 2010. We do not use a balloon. We actually use packing there. So it's a multi-layer fashion, more or less just like we do with the adults: fat, fascia, lata, and a nasoseptal flap, and then bolsters at the time of surgery. In terms of harvest, same principles. Leave that anterior border at the mucocutaneous junction. We harvest along the floor also. We actually find our floor does a great job. It gives us a much larger flap. It increases the width and covers everything. The challenge is obviously the lack of space, and there's just no question, because these kids have done so well without their middle turbinates, we'll just go ahead and take them. And we'll go ahead and take both sides, because, you know, when it's a kid that's 2 years old, you just need some room. Okay, reconstruction has evolved for us over the years. Here we are, end of a case. We've gotten the entire cyst out. Now we need to reconstruct. We'll put a little bit of gel foam down here just to keep it dry, then put our nasoseptal flap fat in, then nasoseptal flap tucked into the epidural space, a little bit of Tisseal, and then we'll put our nasoseptal flap over it. Now the key to this that we used to do was putting the fat, tucking it right into that anterior edge so that it was up against the dura and didn't fall back posteriorly. We have some techniques to avoid worrying about that. And then there's our reconstruction. And you can see that fat filling that spot. Yes, we used to always worry about the fat falling backward. Never did. But like I said, we'll talk about, we're using a button technique now to make sure we don't have to worry about that. So let's talk about the fat sandwich. I'm going to go up a little bit further. So here, this is actually a different case. But what I want to do is show you how we're doing our reconstruction. So here we are. You've gone ahead and removed our tumor. We have our area that needs reconstructed. That's the dural edges there. And you can see dura coming around here, and we need to get that reconstructed. So now what we're doing is we're taking fascia lata, and one large piece bigger than the deficit, one small piece about just slightly larger than deficit, fat that's been taken, so fat and fascia lata from the leg. We take the fat and we roll it aggressively so that it gets a lot of that globular aspect out of it. It's more the fibrous fat. 130 vicryl suture to sort of hold it together as a button. And the goal is this piece is going intracranial slash just on the inside of the dura. The fat is on the dural edges, and this last piece of fascia lata is on the outside. And what that does for us is we don't worry about the fat falling back into the nose. It helps us close it pretty much lickety split now. And fortunately, knock on wood, I have some near me, maybe I'll knock on my head. We've had no leaks using this technique. And our leak rate is now down under 5%. And then once we put that sandwich in, then we'll lay our nasoseptal flap over, a little bit of Tissio, and we'll go ahead and put packing in there. And there's our post-op, and you can see this is actually a fat sat picture here. So this is where the fat sits, and then this is the nasoseptal flap lit up. And I'm going to take it back just a little bit for the one where you can see the fat itself, so you can see that post-operatively as well. Oh, I'm sorry. I'm going to just take it forward like this. Now on that scan, you can see on the right the fat that's present, and the nasoseptal flap on the other side post-op. Okay. So that's how we're closing these now. And then the bolster that we use is Zeroform gauze. We really like it because we can put it into a three-dimensional structure to fill that spot. And with these kids, it's impossible to do debridements in the office in a 2-year-old. That's obvious. I'm pretty persuasive, and the best I've been able to do is do debridements in the office in about a 5-year-old. But we will leave them either in the hospital or go home and come back, and we'll go back for a second look somewhere between 1 to 2 weeks to take out the bolster if they're not going to tolerate the removal in the office, and then make sure everything's laid down in good position. With these kids, it is absolutely amazing how well they heal. And so that it makes life much easier. Now, kids will let me, I'll follow up post-operatively and perform limited debridements in the office. The younger children, they're getting routine MRIs anyway for their craniopharyngioma. We'll just go ahead and check to make sure that the sinus mucosal disease resolves. It appears longer for the older children that allow cleaning. There's no question debridement does work and help. Now, if they're tolerating sinus irrigations, I like the Neilmed bottle, I will add Bactroban. Now, not Bactroban in the ointment, but Bactroban in the dry powder. So you'll have to get that from a mail order pharmacy in the US. I do not know how you get a hold of Bactroban powder internationally, but you put that in. And if you guys want to send me an email, I can send you my recipes for that. It really helps quite a bit in this crusting in the relatively early post-operative course. So let's take a look at the nasoseptal flap. So immediately post-op, I like how my fellow put a T there for tumor because you didn't know what it was. Here's the fat that's present, and then here's a nasoseptal flap coming in. And you'd like to see that light up. It proves the vascularity of it there. And really the things you want to do is you want to see that it's fit tight up against that spot, that there's no areas around it that are abnormal. And there is where our packing is, and that three-dimensional packing. I know that people say, oh my gosh, I don't want to use Vaseline gauze as packing. It's antibiotic gauze. If I was in the UK area, I'd probably be calling it BIP gauze. But I'd put that in there to get that flap to sit down nicely, and it creates a structure that's the same 3 dimensions of the inside of that kid's head. How does it evolve? Well, it switches from that C-shaped configuration, which is immediately post-op, flattens out, and by 6 months, you're kind of sitting down flap, and it's thinner and lays across the area nicely. The fat itself compacts also. So here's pre-op, immediate post-op. The fat seems like a big area there, but it compacts down also. And here's 9 months later where it compacts. So if you see this scan at 9 months, don't be concerned that the fat is packed down. That's actually expected. And as long as the flap's in good position, they're going to do well. Here's one of my patients at 6 months post-op, septum, inferior turbinate, lateral nasal wall. In this situation, we had left turbinate because this kid was a little bit older. I think she's about 7. Nasopharynx, and there's our flap in position. You can see how they've just healed so beautifully, and that does really well. And you can keep them clean, and if they irrigate, they're going to be a nice situation. Okay, so that kind of goes over the step-by-step process of taking care of these pediatric skull-based tumors. Let's just do some cases one by one, pick out some of the thoughts of each one that's helped make us successful and go from there. 15-year-old female, prolactinoma, compression of the optic nerves and vision loss. So in this situation, there's some element of it's pretty similar to thinking of an adult. Go ahead and get your approach, which is more or less the same each time. Take down the bone anteriorly, and then we're going to be at the cystic area of the prolactinoma. Again, careful making sure you get this instrumentation quarter as wide as you can do so that you have a nice area to work from. We're going to use a U-shaped flap through the dura to go back into the cystic area itself. And there's our making our incisions to do that. And then we're going to raise that flap, and then we'll be right there into the prolactinoma itself. Go ahead and send some tissue for frozen, and then as we enter into the cyst itself, we'll get that return and flash of fluid, and then we'll go ahead and decompress. Now, once this type of situation has happened, the question becomes, how do you reconstruct something? For this situation, we figured this was small enough we probably didn't need to do a separate incision for fat and fascia. And you'll see each time people do different ways for reconstruction. I really like the fat and fascia from the leg, but obviously that comes with some deficits too. So if you don't need it, better to avoid if possible. In this situation, because it was a prolactinoma cyst like this, we actually used a little bit of Duragen. We're going to slip that into the epidural space and then lay a graft over it from there. So that's our Duragen in place. And then we're going to lay a graft, a little bit of Tisseal. And I do like to put a small amount of Tisseal in between the layers, although some people don't think it's a good idea. If you do just a drip or two of Tisseal so that it's not such a thick ball, they do much, much better. And then the nasoseptal flap, and we're done in this situation. And you can see the difference there pre-op and post-operatively after things have been decompressed and we've improved our situation. So that was a prolactinoma. Let's do a craniopharyngioma, 23-year-old month female, ataxia, left leg weakness, poor oral intake. Here is her MRI. You can see that is a massive craniopharyngioma. Her lateral vents are mashed down, and you can see the calcium that's present. So we know we're going to need to open this up and intersinus bag and clear things out. Now we're concerned about optic nerve pallor on the ophthalmology exam, so we know we've got to get her in relatively quickly. She's got a non-pneumatized sphenoid, so we know we're going to need to do a lot of drilling to get there. It's going to create nasal narrow quarters for us, and then we've got to think about how we're going to take care of her reconstruction and leak. So the plan is for endoscopic approach, resection of tumor, reconstruction of skull base. So this is a long video, so I'll kind of hop through some of the parts of it. But at the same time, it shows us so much about what we need to do. So this goes pretty lateral, goes pretty far anterior, but because as we open things up, we'll be able to, like we say, drain Santa's bag. It'll come down for us in those areas. So first step, take a look in the nose, kind of see where we're going to go. Push your inferior turbinate to the side. Go ahead and take your middle turbinates, then open up your sinuses. We'll go ahead and move along a little bit here. And once that's done, now we're going to be, here comes our nasoseptal flap. Lay that down into the nose. So nasoseptal flap has been taken, drop down, posterior septectomy. So we're going to take out that area of the posterior septum. That'll give us room to be able to do bi-nostril approach. Scope on the left side, instruments on the right side is mainly the way we like to do things. And then at this point, we're going to need to drill through this bone and basically recreate a sphenoid sinus. So we do like a little bit of suction bovie cautery at this point to dry things up. and then we're going to be drilling for a while. So after we get our drilling working along, we're going to drag forward a little bit until we've got our sphenoid sinus created. Now look at the difference when you move from the cancellous bone to the harder bone. You can actually see that appear. You obviously notice we're doing a lot of image guidance to do this. Now you thin down that bone and push gently on it. You'll sort of see a meniscus appear when you're getting to your dural edge against the bone of that epidural space. It'll help you know you're in the right spot. And then go ahead and take off the rest of the bone. And you really want to do as much of your endoscopic endonasal portion before you enter intracranially, because once you go in intracranial, you've got a lot of drainage of fluid and so on, and it makes it much more difficult. So really get your quarter as big as you can. Here we are, we've now gone, we're going anterior so we can get more arrangement there. Most of the time, circular sinus has been mashed by the pressure of the tumor and there's no bleeding, but if circular sinus appears and starts bleeding, you have no choice. You've got to cauterize that and take care of it. And then once you've done that, you're going to be able to enter into the dura and we'll get ready to take on the cyst. So at this point, we're going to be careful. The other thing that you've got to worry about is that sometimes the optic nerves can be mashed anteriorly by this dura. There is optic nerve right there. If we had just cut indiscriminately, this whole process would have been a disaster. There will be a lot of CSF leak at this point sometimes because as the cyst drops back, you have that CSF space that opens up, and now we're into the cyst itself. And you're going to see this pulsatile nature. There's the optic nerves in good shape there. And now we're going to go ahead and open up Sana's bag and begin to empty it. There's the optics coming. So we've got to first get that free of the optics. Again, this gentle retraction is acceptable and really helps a lot. And then we're going to slowly but surely get this open and move things along. So once you've got the cyst itself open, so we're going to go ahead and get ourselves into the cyst. Now you can take out the contents and then start working on the cyst wall and removing portions of the cyst wall. And now that we're here we are superiorly. I'm sorry, that's a basilar down there coming through, and we're still going to, that was inferiorly portion. And then we've got to remove some of these portions of the calcium that can really make things difficult. So I'm holding the bag open, the cyst wall open to remove portions before we then try to take the entire piece out. And again, this is a long process. This video is a little longer. It's about 8 minutes of video, but it's almost a minute of video for an hour of surgery in some ways. And I'm going to move us along now that we're further on this intraoperative dissection and bring us along till we've got each of the step. Here we come. Here comes the last one of the larger pieces of the cyst wall. Again, hand over hand technique sometimes to help remove it. It is okay to have a little gentle traction, but each of these spots you need to be careful as you dissect it free. Fortunately, the tissue planes are usually quite good, and we can go ahead and get each of these pieces out, turn and turn. This reminds me of the fact that sometimes this calcium is larger than the hole we're trying to take it out of, and you do need to cut it up intracranially to remove it first. And at that point, we finally have our deficit. And go ahead and check around. Angled scopes are key here to look at all the areas to make sure you've got all portions of craniopharyngioma removed. And remember, a gross total resection is key to avoid recurrence, but at the same time, it is benign disease and you don't want to cause damage either. And then you've got your deficit that you've got to take care of. So at this point, we're going to use a little bit, sometimes we'll drape across the optic nerves as close, a little piece of Duragen just to keep it safe there, and then put in our fascia lata into the epidural space and fat intracranially at that area of the junction of the dura, and then a nasoseptal flap over everything. So first step, fat. Now you're going to see me take the flap and put it into position, tuck that into the epidural space, a little bit of tissule, and then we're done. And so here we are at the end of the case and fill it up with packing. So here she is post-op day 2. That's what I'm talking about, the fat piece that's present, and then our nasoseptal flap that's in good position. And yes, they do often ends up with some pneumocephalus immediately post-op. Here's pre-op, here's post-op. Fortunately, we're already getting the vents back into good shape. And at 5 months, things are in pretty good shape and she's doing quite well. Unfortunately, in these situations, these large tumors, they've pretty much lost all pituitary function. But other than that, in good shape. Okay, so how about revisions? So one of the things that we try to do is if we have someone that does have pituitary function and have this and have a large craniopharyngioma, we've been working towards the idea of marsupializing it, draining it, and then hopefully having it not recur with any sort of speed, give that kid a chance to grow and not interrupt pituitary function. And when that happens, not a big deal if we have to go back. Bring down your nasoseptal flap. It will detach just fine. Go ahead and recreate your instrument corridors, open things up widely, and then at that point, go ahead and do a complete resection if necessary. And so that's what we're doing in this situation. Our goal, obviously, for these kids is if somehow we could, in the situations where they still have pituitary function when we get them, we want to try and get that craniopharyngioma out without causing loss of pituitary function, which in these larger cases obviously is difficult. So I'm going to move ourselves along here because this is pretty similar in our other dissection area, and the revision part, fortunately, is all about the anterior portions of the nose, how you set that up to go to it. And if you haven't interrupted and scarred that cyst wall and you keep your incision into it anteriorly, the dissection is pretty similar to a primary case. So nothing to worry about draining it. Here we are with a gross total resection. You got optic chiasm there nicely going up towards the vents. We have a nice size deficit. I'm going to open up my area into the epidural space, tuck my fascia lata low into position, a little bit of duragen over the optic nerves, then some fat in to fill in this space here, and then we'll flip and there's the fat again, even with the dura, and then tuck into the epidural space here, and then an overlay flap from there, a little bit of tissial, and then a nasoseptal flap, and they'll do well. And here we are. So this set of films shows us pre-op, drain the cyst, buy some time. There's our nasoseptal flap. Cyst is recurred, unfortunately, now taken to the OR for gross total resection. And this is a successful end result. There's our packing right there that you can see. It's kind of nice to be able to see that on the films. So what are the limitations? They're similar to adults. It's really that lateral exposure you've got to be careful about. And with a large crania, the instrumentation sometimes gets a little bit short for tissue dissection. And here's one of our particular cases of a limitation. You can see out there laterally, you've still got some recurrence of craniopharyngioma. This is a post-operative MRI, but the problem is here is the stalk. You've got optic here, 3 coming across, PCOM, and there's our little piece, and we just frankly couldn't get it. The problem is, if you injure 3, it's almost like making the patient blind because they won't be able to open their eye. So better to leave this little bit behind in this situation. Let's do some other cases. Pontine cavernoma, 16-year-old, otherwise healthy male, severe headaches for 5 months. Otherwise, not a whole lot going on except when we got the MRI, and there's his pontine cavernoma. So a lot of the same treatment plans as you do with adults. The overall clinical picture, in this case, cavernous malformation, bleeding risk of 5% per year, subsequently 30% a year after. So need to go ahead and remove this. We have a couple kids that this was found on, they were playing basketball, had to remove it, and then got them back into action, which is exciting. So this is about our 3rd or 4th one that we'd identified. The situation is pretty similar in terms of the approach. Middle turbinate, open the sinuses, nasoseptal flap, wrap around flap, put all those areas together, and then you've got to get further inferior than you would for a craniopharyngioma. And I'm just saving this part here so you can see how far underneath the floor we go to get our flap, because it gives us that much wider flap that's going to make us happy for closure. And then at this point, sphenoid sinus open, and we're going to start drilling down, raising that flap area that Danny showed so nicely with Brad Otto, leaving it a little bit exposed. They went much further down than we're going to go here, but we're going to keep drilling down through the clivus and take out this area clivus here so we can get to that spot where that cavernoma is present. So as we're working along, again, you have to take your time to make sure you have a good corridor present and get yourself all the way back. And the first thing you're going to run into, unfortunately, at the dura right behind it is you're going to have basilar show up. So very careful just to incise the dura and not cause any issues with basilar. So here we go, taking down superiorly and inferiorly. And again, you do want to make as wide a corridor as you can. You can see that no matter how much we try, this still feels very tight. And then there's our cavernoma that's present. We're going to go ahead and resect a little dura to make sure we've got enough room to take care of it. And then go ahead and begin dissecting and remove that cavernoma. Once it's out, then we're going to have to close things up. And so here it comes out. Perfect. And then the nice thing about removing these cavernomas is there isn't actually a lot of bleeding once you've gotten around all the aspects of it. Image guidance is key here to make sure that you're in the right spot. Now closure, put a little bit of gel foam or Duragen into that deficit, then flap, fascia and flap piece by piece. Careful not to do too much decompression on this. We'll actually usually use a couple pieces of our fascia lata and then lay in our flap. And it's okay to put fat into this area here to create some packing and some extra pressure there, which we're going to do in this situation. And then a little tissue, and we're done. So there goes a little bit of fat just to create some pressure on that flap so it holds down and stays sucked down into the area. So that was a pontine cavernoma. How about a petrous apex cholesterol granuloma? So another thing they'll present with these children, again, similar fashion to adults, a big petrous apex cholesterol granuloma that's causing compression on 6. And so we need to take that out. Careful with these that you have some room to shoot between the carotid and the basilar to get back there. And in this situation, it was perfect for an endonasal approach because it had pushed into the sphenoid sinus so far that you've got some room there. Now, approach is pretty similar. You're going to want to raise it, open the sinuses, and raise the nasoseptal flap. But the plan with the nasoseptal flap in this situation is not to cover over the cholesterol granuloma, but to instead line the cavity so it stays open forever. If this is drained and exteriorized, you will have no problems in the long term. And the best way to do that, principle I learned from Aldo Stam, so Aldo, if you're somehow on here, I'm going to give you another shout out and thank you, is to make sure you cover all bone with vascularized tissue if you can. Even a free graft is fine in so many situations. And I learned that from his choanal retresia repair, and it's a principle that I'd like you all to think about and always use. If you just leave exposed bone, things want to scar down. If you can just get that bone covered, again, free graft. If it's a free graft, the floor is probably my favorite. If it's vascularized and nasoseptal flap, to give a shout out to Rick Corral on introducing how wonderful that is. That works so fantastic to cover that bone and allow these areas to heal open. So now we're all the way into that large cyst, suctioning things out. The carotid has been displaced. You can see it beating there on the left. We're going to irrigate, get that cleared out as far as we can. It doesn't, you know, you want to get all that little bits of cholesterol granuloma, but admittedly, if you can get this to stay open, it's the cholesterol is going to reappear. You're going to have to see this person in the office. I will irrigate these in the office and just put a suction in there and suction them out. And as long as they stay open, my record right now is I've got a woman that I did in 2003. Noam Cohen was the fellow, and she's still open. And this is what you'd like to do. Now, if you can get 360 degrees like I did on this case, you're even much happier. And then the next thing I'm going to do is put a silastic stent in, because I want something that's soft to sort of push there and hold that down. Leave that stent for at least 2 weeks, 2 to 3 weeks. If you start leaving it longer, like 4 weeks, your issue is going to grow biofilms on it. And there's a CT at 1 month showing just how nicely we've got that opened. And so that's going to get, and he's continuing to do well long term. So in conclusion, endoscopic pediatric skull base surgery can be performed in a safe manner. The key is to identify which patients this can ideally be performed on. You have to do this in a multidisciplinary team approach. IGS is very helpful. Outcomes, you really want to see that long-term recurrence-free rate and the risk-benefit ratio of recurrence versus pituitary function. I keep coming back to the pituitary function. That is the last holy grail for us. We're going to figure out how to get these cranios out without damaging pituitary and get them early done. And we're also going to we also send these for sequencing. It turns out the adult craniopharyngiomas, a big advance for us was that they are susceptible to BRAF inhibitors. So adult craniopharyngiomas, if there's a recurrence, you can give them a BRAF inhibitor, not worry about them. The pediatric ones are usually adenomatous, sorry about that. And we do not have any treatments for them yet, but that is our future. And so in conclusion, I'd like to thank you for taking time to listen to this lecture. And there are my kids in younger days with Rocky. This slide used to say at the bottom of it, I'd hope to host you in Philadelphia, but now after our recent election, I like to point out the good things do happen in Philadelphia. And with that, I'd be glad to take any questions and discuss.
Stealth Station ENT, the advanced image guidance system for the full range of navigated ENT procedures. Engineered with you in mind, based on decades of scientific, clinical, and engineering expertise, we're expanding what was previously possible with image-guided surgery. Flexible and elegantly designed, Stealth Station ENT streamlines the workflow so you can maintain focus. The flat, under-the-head emitter allows for an efficient setup. Its design allows for a large EM field. Easily find your patient's exam through a variety of network options, super speed USB, or optical disc. The visualization and modeling features give you the perspective you need. Leverage data from multiple sources to create high-resolution 3D images. View structures and pathology with high fidelity. Registration expertly matches the three-dimensional positioning of the patient with the preoperative images used for navigation. Patient registration combines registration methods and provides numerical and visual accuracy feedback. Leverage the latest technology for advanced surgeries. See more, do more. The result? You have an image-guided perspective like never before. With Stealth Station ENT, you're at the forefront of ENT surgery. You are Stealth.
Thank you very much, Jim, for that outstanding lecture. I would like to start asking a few things. In adults, it's frequent practice to get a CT scan, like just after the case, you have a baseline in case of any complications. What about these 2-year kids? What do you do in these cases? Do you have an MRI and a baseline MRI or something like that?
Well, admittedly, Claudio, it's the States, so we don't seem to mind spending a lot of money. So we usually actually get an MRI immediately post-op. And what happened for us was we were getting CTs post-op, and we realized we were just getting small amounts of information, and we said, why don't we just go ahead and get MRIs and get a lot of information? So we get MRIs immediately post-op. And then admittedly, from the sinus perspective, if we can do it endoscopically, we're just going to look endoscopically. If neurosurgery, we'll be getting them every 6 months for the first year or two, and then yearly after that. So what we do is after neurosurgery's gotten the MRI for follow-up, we'll then just take a look at it for the scans, for the sinuses, and we just see how much disease is present on the sinuses. If the patients are asymptomatic, then we just keep an eye on them. And it's been, with these kids, it's been nice. I tell adults, especially malignancies, if I'm removing their tumor endoscopically, they've got almost a 50% chance of some sort of sinus disease post-operatively, and they'll end up back in the OR with us potentially. The kids have done very well. We're over 50 kids, and I think we've had to take 1 back for sinus disease.
Awesome. There's a question regarding if you use the Doppler while doing the sphenoid.
Yes, you definitely have the Doppler present, and that plus image guidance, anything you can do to help you feel more comfortable as you're opening that corridor. And yes, the more you do this, the more you learn to make that corridor as wide as possible.
Perfect. I don't know if it has happened to you, hopefully not, but there's a question regarding if there is any difference managing ICA injury in pediatric regarding adult population.
So first of all, fingers crossed, never going to have to deal with it in a kid. So we have not had that happen. And no, there's no difference. And you know, hopefully all of your teams, your endoscopic tumor teams, have run the drill so you know what to do, providing pressure, get some muscle on it, get down to interventional radiology, all those steps. I mean, we know them all. And yes, it's important to practice. Have not found any difference between children and adults.
Perfect. I would like to ask you, completely out of my ignorance, but regarding the length of the nasoseptal flap in a 2-year-old kid compared to an adult, are you worried sometimes that it's not going to reach the more distant part of your defect sometimes? Because you said it could be wider because you take it down the inferior turbinate, but what about the length?
So it hasn't been a problem because this, even though we're opening up we're drilling out a sphenoid, right? So you've made more distance, but we've been fortunate. Come on anteriorly to even with the inferior turbinate and get down on the floor. You're right, that does make it wider than it needs to be. And then what we find useful is that if you need to drill down that sphenoid floor so that so the flap doesn't come forward and then backwards to fill that sphenoid you've created, drill that all the way back. And we fortunately have not had, knock on wood again, have not had any issues with the nasoseptal flap being too short.
Perfect. There's another question regarding the use of fasciolata. You said you use it, but they're asking if it's always autologous or you use banked one.
Always autologous, and you know, everyone has their own feelings on reconstruction, and I've done many different ways of reconstructing, but I always come back to one of my patients a long time ago had been taken care of by Jack Bordley when he was at Hopkins. And I like to use this quote. The patient said to me, Dr. Bordley said you should only put tissue from your own patient into your body because that always works better. And I have to admit, having done so much sinus things over the years and pulled out methyl methacrylate and bioactive glass and bone source and all sorts of things, if you can use the patient's own tissue, it's better. And so That's why I try to do that whenever I can. And I understand other people would say, oh, it's a separate incision, the leg doesn't work as well, but I'm willing to agree to disagree, use autologous tissue if possible.
Perfect. Thank you very much, Jim, for that outstanding lecture. I think that in interest of time, we are a little behind, and we'll hand back to Ashok. Hi, Jim.
Thank you, Jim. Excellent lecture, as always. Great review of pediatric skull base surgery. We had a great review of pediatric sinus surgery yesterday from Reuben Campbell, and this follows with that. So perfect. And thank you, Claudio. Wonderful hosting. Your great questions. We just did a mini poll while you're having question and answer session. The results are very interesting. We asked about what do you wear for anterior skull base surgery, and almost 50% of them are FFP2 to N95. So does that, what do you think, Jim? What is your practice?
Well, my practice is more because of the demands of Penn than everybody else. I see Zara over there listening in from Stanford, and she's done a lot of the work here. Thank you. And Brad, always good to see you too. Had to put the shout outs quick. At Penn, if you do not have an N95 on in what's defined as an aerosol generating procedure, and you don't have goggles, see, these glasses don't count, you're out if you find out later someone's positive. So in the States, you know, going back to our politics, we're not doing so well with this whole COVID-19 thing. And we got a lot of patients with it. We test everybody before we see them. But the problem is, in my situation, for example, I had my N95 on, I was wearing my glasses, and seeing a patient post-operatively, took some packing out of their nose. It was an epistaxis thing. It was a week and a half later. 3 days after that, we got a call and they said, he's positive for COVID. He was probably attending a political rally or something. So all of a sudden, I was actually not worried for myself. I had my N95 on and my glasses, and I just took out a little packing, but I was out for 8 days. Got my negative test, and they said, you're done because you didn't have goggles on. So now I have some special goggles on. So Ashok, for us in the States, the answer is more, we wear the N95 and the goggles and everything just to keep the public health people off our back. I do think it's safer, but I'm doing it so I get to keep operating and seeing patients, frankly.
Okay, interesting. What is your take, Zara? I thought you probably are more of Papa.
Yeah, you know, I agree with Jim that definitely we have a lot of administrators now sort of watching over everything we're doing and making sure that we're doing the right thing. And I do think that the sort of impression that it gives on our patients and making them feel like it's safe to come into the healthcare system keeps people coming to the healthcare system, which is important also. But yeah, you know, for skull-based surgery currently right now, we are using N95s and face shields and things like that just because of the increasing prevalence. There was a time where our prevalence in the Bay Area was so low that I actually had gone away from wearing that again, but now it's climbing again, as everyone knows. So we're back to that.
Okay, thank you.